Hello, good evening, friends. I, Dr. Anuradha Dhawan, welcome you to today's session. The today's session is in ophthalmology, a short revision. So before we start the session, let me just inform you that you can download Unacademy app and you can unlock Unacademy free plan by using referral code Anuradha I. And I'm sure that will open you to a feast, an academic feast which is being offered by Unacademy. Okay, so let's start with the today's session. Ophthalmology, a short revision. The purpose of today's session is to kind of trigger the beginning of revision for the upcoming NEET PG 2021. We'll be touching upon some important topics. We have seen this year the entrance exams, they have shown us that various topics, they have been coming in the exams, especially there is change in the pattern of the paper in certain entrances. Certain topics are being asked repeatedly. So let's kind of trigger our revision by starting with this short revision in ophthalmology. Okay, so welcome to the first slide. So our revision we'll be discussing few MCQs and the related important points regarding them. Let's start with the first MCQ. So a 56-year-old man is being investigated for glaucoma. Okay, so this is a clinical case scenario. A 56-year-old man is being investigated for glaucoma. His intraocular pressure is 25 millimeter mercury in the right eye and 28 millimeter mercury in the left eye. Okay, now which of the following optic disc finding is most indicative of? It is most indicative of glucomatous optic nerve damage. Okay, which is most indicative of glucomatous optic nerve damage? Increased cup size, optic disc pallor, peripapillary atrophy, or notching of the neuroretinal rim. Okay, so we know that different characteristic optic nerve changes are seen in a case of glucomatous damage. So the choices which are given to us out of these, which one are the most indicative of glucomatous optic nerve damage? Okay, now if we see here in the first choice, we know, if we talk about the first choice, we know the increased cup size can be physiological also. Okay, increased cup size can be physiological also. Optic disc pallor, that is usually associated with optic atrophy, can be seen in various other conditions, right? It can be present as a part of post-CRAO, central retinal artery occlusion. It can be following toxic optic neuropathy. It can be following trauma. So optic disc pallor can be associated with various conditions. So this is not characteristically indicative of glucomatous damage. Okay, then we have peripapillary atrophy. So atrophy around the disc area, again the peripapillary atrophy is not exclusive of glucomatous optic nerve damage. Okay, so out of these choices, the choice D, that is notching of the neuroretinal rim. What do we mean by notching of the neuroretinal rim? That indicates localized nerve fiber loss, which is most indicative or most characteristic of glucomatous optic nerve damage. Okay, so here the right answer to this question is your choice D, that is notching of neuroretinal rim. Okay, right? So let me just take you through the various changes which we see in a case of glucomatous optic nerve damage. Okay, so if you are seeing here, this is optic nerve. We know the optic nerve has nerve fiber layer which can be divided into the upper nerve fiber rim, the lower nerve fiber rim, the temporal nerve fiber rim, and the nasal nerve fiber rim. Okay, and we know this nerve fiber ring normally follows a pattern which is known as isn't pattern. What is this isn't pattern? We know that the inferior rim is normally the thickest rim of the optic disc, followed by the superior rim, then the nasal rim, and then the temporal rim. Now in glucomatous optic nerve damage, this isn't rule is no longer followed. Okay, there is thinning of the neuroretinal rim, which is because of the nerve fiber layer loss. And what is nerve fiber layer? It is axons of the ganglion cells. We know in glaucoma, it is your ganglion cells which are getting damaged, which die, which leads to nerve fiber cell layer loss, which results in neuroretinal rim thinning. Okay, so this starts in the inferior rim first of all, and then in the superior rim, which makes the cup now appear vertical. So vertical cupping is highly suggestive of glucomatous optic nerve changes. Okay, then asymmetrical cupping, when the cup between the two eyes has a difference of at least 0.2 or more, that is known as asymmetrical cupping. That is again highly suggestive of glucomatous optic nerve damage. And then, as our MCQ was asking, the neuroretinal notching. Notching means the localized loss, that at a particular point there is localized loss of the nerve fiber layer. This is again highly characteristic of glucomatous optic nerve damage. Now, as the loss of the nerve fiber rim occurring, the many changes are seen in the optic disc. Okay, so what are these changes? As we see, the vessels which are embedded in the nerve rim, they become now bared because the rim is becoming thinner, which is known as baring of circumlinear vessel. Okay, the vessels, they appear to be dipping in the cup and then coming onto the edge, which is called bayoneting of the vessels. Okay, since the superior and inferior rims are becoming thinner, nasal is the last one to go. These vessels, they keep shifting nasally, what is known as nasalization of the blood vessels. Okay, and then when the rim is becoming less and less, the dots, the openings of the lamina cribrosa, they become more prominent, what is known as laminar dot sign. Okay, and then there can be associated a splinter hemorrhage on the optic nerve head or in the peripapillary area, which is again indicative of glucomatous optic nerve damage. This is especially seen in the cases of what we call as normotensive glaucoma. Okay, normotensive glaucoma. So these are the characteristic glucomatous changes which are seen in cases of progressively increasing glaucoma. So here the right answer to be marked is your notching of the neuroretinal rim, because the other findings, they are not exclusive of glucomatous damage. Okay, right. So now moving on to another case scenario. So look at the question over here. Okay, so you can answer the question on the chat. Okay, so look at the question here. Let's read the statement. A patient is subjected to the test which is shown here. So this is an image which is being shown to you here. So this is a test which is being performed on the eye. First of all, we have to, of course, identify that what test is it. Okay, and then the question is asking you what is the interior most structure seen in the given image. Okay, so can we say what image is this? What test is being done here? What test is being done here? What is this image telling us? This image, friends, is of a gonioscopic examination. This is a gonioscopy being done. Okay, what is gonioscopy? Gonioscopy is examination of the angle of the anterior chamber. You know, angle of the anterior chamber cannot be seen directly. We have to use what we call as gonioscopic lenses to examine the angle of anterior chamber. Okay, when we examine the angle of anterior chamber, the angle contains different structures. Okay, and this is what we are seeing here. This whole thing, what we are seeing over here, is the angle of anterior chamber. This is your iris. This is your iris, and above is your cornea. Between the cornea and the iris is your angle of anterior chamber, and the structures which are seen in the recess of the angle of the anterior chamber helps us to know whether the angle of the interior chamber is open or it is closed. Okay, so this is done by doing the test of gonioscopy. Okay, so what is the interior most structure when we are doing the gonioscopy? Interior means towards the corneal side. Okay, so the choices given to us are scleral spur, trabecular meshwork, ciliary body, shawl based line. Now, since cornea is the interior part, iris is the posterior. If we move from cornea to iris, so that is how the structures are seen in gonioscopy. When we are looking at the gonioscopy, the first structure, the interior most structure is your shawl base line. Shawl base line. Shawl base line is the interior termination of the descemet membrane. Okay. After shawl base lines, we see trabecular meshwork. Trabecular meshwork. The pigmented is your trabecular meshwork. Then after that, there is another white band, which is your scleral spur. Okay. And then in the last is your ciliary body. Okay. So this is from anterior to posterior, the structures seen on gonioscopy. Okay. So what shall be the answer of this question? Shawl base line is the interior most structure seen when we are doing gonioscopy. So this question is telling us that we need to recognize that what test is being done. This is your gonioscopy test, and then we must know that what are the structures which we see in the angle of interior chamber, right? So lately the glaucoma has been a very kind of favorite topic with the examiners. Okay, moving on to the next question. So this is the spot diagnosis for you people. So name this sign which is seen in thyroid eye disease. This is a thyroid patient. So name this sign which is seen in thyroid eye disease. So what is most prominent over here? What is the most prominent thing which is visible to us in this picture? Okay. See, normally the upper lid should cover 2 millimeter of the cornea. Upper lid normally covers 2 millimeter of the cornea. So upper lid position should be something like this. And here in this picture, what is there? There is lid retraction. There is bilateral lid retraction, which is more in the left eye, lesser in the right eye, but this lid is also retracted and this lid is also retracted. Here the retraction is so marked that we can see the sclera also. The sclera superiorly is not normally visible. So what is this known as? That scleral show, that we can see even the sclera due to markedly retracted upper lid. Okay. So this sign is known as Dalrymple sign. This sign is known as Dalrymple sign, and this is the first lid sign to occur in a case of thyroid ophthalmopathy. Okay. So there are various lid signs and various signs which are associated with thyroid eye disease. So here is a list of that. Dalrymple sign, as I told you, upper lid retraction. Von Graffe sign, the lid lag. Lid lag means when you are moving, when you are looking downward, the globe moves downward and the lid follows it. If the lid is not able to follow the globe, this is known as lid lag. That is again a feature of thyroid eye disease. Then Kocher sign. Look at this patient. It is giving a staring look. That is known as Kocher's sign. Then these patients have infrequent blinking, which is given the name Stellwerk sign. And these patients also have poor convergence. That is known as Mobius sign. So these are the signs which are associated with thyroid eye disease. Okay. Let's move on to the next question. Again, a spot diagnosis for you. So this is the image of a child, a young child. So what is the diagnosis over here? What is the spot diagnosis over here? So again, look at the as an external examination of the eye. This eye, the external examination is normal. Okay, the lid is in normal position. The external examination is normal. Look at this eye. Here it is covering more than 2 millimeter of the cornea. Okay, so it is drooping. This lid is drooping of the upper lid is there. This is your ptosis. Okay, this is what is your ptosis. And from the morphological features, I can tell you it is a congenital ptosis, that is the ptosis since birth. What is making me say this? The absence of lid crease. So this is the normal lid crease on this side. Here you see absence of the lid crease is there. So absence of lid crease is indicative of that this ptosis is congenital. Why the lid crease is absent? Because the congenital ptosis is due to maldevelopment of levator palpebral superioris muscle, LPS muscle. LPS muscle helps in elevating the lid, and some fibers of the LPS, they insert into the skin of the eyelid, which helps in making the eyelid crease. So since the LPS is maldeveloped, so the lid crease is not properly developed. Okay. Another important feature of congenital ptosis is lid lag. Yes, the same lid lag which we talked about in thyroid eye disease. Lid lag is present in case of congenital ptosis also. Again, because of maldeveloped LPS, which is not able to relax when the eyeball is moving down. Okay, congenital ptosis, mostly it is unilateral. It can be bilateral. If it is bilateral, the child may present with chin lift and amblyopia. So these are the features, the clinical features which help us to make a diagnosis of congenital ptosis. Okay. So these questions, they can come as image-based questions. Okay. Okay. Let's move ahead to another case scenario. Okay. Let's read the statement. A 65-year-old hypertensive patient with past history of central retinal vein occlusion. Okay. So what are the positive points? An elderly patient with hypertension, past history of central retinal vein occlusion in right eye, is now presenting with following slit lamp finding. So slit lamp image has been given to us. What is the most appropriate management of this patient? Okay, so first have a look at the slit lamp image, because first we have to identify that what is wrong or what is the pathology here. Only then we can decide about the management. So patient of central retinal vein occlusion, and if we look at the iris, we can see there are multiple vessels on the iris surface, new vessels on the iris surface. So it is your iris neovascularization which is visible on slit lamp examination, visible on this given image. Iris neovascularization is also called rubeosis iritis. Rubeosis iritis. Okay, and we know rubeosis iritis is one of the late complications of central retinal vein occlusion, and it can lead to what is known as 100-day glaucoma or 90-day glaucoma. Okay, because this usually happens after 3 months of onset of CRVO. Okay, so now we have to look at that what the question is asking. What is the most appropriate management of this patient? Okay, pan-retinal photocoagulation, laser iridotomy, laser trabeculoplasty, laser capsulotomy. Now friends, for deciding the management, we have to see that what is the basic reason for this iris neovascularization. Basic reason for this iris neovascularization is retinal ischemia. Okay, because in central retinal vein occlusion, the retina becomes ischemic. This ischemic retina is producing increased levels of VEGF, vascular endothelial growth factor. This increased VEGF leads to rubeosis iritis. So the root cause of the problem is in the retina. So to decrease this ischemia, to decrease the levels of VEGF, I will do pan-retinal photocoagulation, which will bring about regression of this iris neovascularization. Okay, this is not requiring iridotomy. Iridotomy is done in the cases of angle closure. Trabeculoplasty is the choice of surgery for open angle glaucoma. Laser capsulotomy is done for after cataract. Okay, so here my pathology, the cause for the pathology is in the retina. So I'll be doing pan-retinal photocoagulation. Okay. Okay, another important topic. Let's see the case history. A young man presented with decreased vision. His examination is as shown in the picture. Okay. What should be specifically asked in the history of this patient? Okay. So young person presenting with decreased vision, and they have again given us a slit lamp picture. So what is most striking in this slit lamp picture? Okay, so we see cornea is clear, we see iris is normal, anterior chamber is appearing normal, but what is abnormal here? We are seeing this lens opacity which has a characteristic morphological appearance in the form of rosette. Okay, so this is your rosette cataract. This is rosette cataract. So rosette cataract is seen in the cases of blunt trauma. Okay, so what should be specifically asked in the history? The choices were history of steroid use, history of trauma, history of skin allergy, history of diabetes. We know steroid use can induce cataract. Systemic steroids, they increase the risk of cataract development, but the cataract seen with the prolonged use of steroid is posterior subcapsular cataract. Skin allergy patients, maybe atopic dermatitis in which the shield cataract is seen, or if they are on steroid, again the posterior subcapsular cataract will be seen. Okay, diabetic patient will develop snowflake type of cataract. So rosette cataract is associated with trauma, so we should ask history of trauma in this patient because we have diagnosed him with rosette cataract. Okay, right. So moving to next question. Identify the procedure being done in the given image. So you can see in this image an instrument is being used and a procedure is being done. So we have to identify which procedure is being done in the given image. Okay, is it measurement of the squint? Is it measurement of the proptosis? Is it measurement of the ptosis, or none of the above? Okay, so try to identify this instrument which has been placed at the outer canthi of the two eyes. This is your Hertel's eggs of thermometer. This is your Hertel's eggs of thermometer. The procedure which is being done is eggs of thermometry. That is for the measurement of the proptosis. Okay, it is not measurement of squint, the ptosis. No, this is obviously not the choice. There is something being done which is here measurement of the proptosis. Hertel's eggs of thermometer is used for measurement of proptosis, right? Okay, right. So this is an investigation based question. So let's see what's being asked. All of the following can cause the condition shown in the image given except. Okay, so lately there was a similar question, though it was not image based, but there it was theoretical question. So here we have the image, we have to make diagnosis from the image, and then we have to see that what is the right answer. So can cause the condition. First of all, let us identify what this condition is. Which is this investigation? This is your OCT of the macula, optical coherence tomography of the macula, okay, which tells us about the morphology of the macula. And what is most characteristic in this image? We are seeing these cystic spaces, multiple cystic spaces we are seeing, and we are seeing that the thickness of the macula is increased, normal foveal contour is absent. So this is giving us an OCT diagnosis of cystoid macular edema. Okay, now we have made our diagnosis and now we have to answer the question. All of the following can cause cystoid macular edema except, okay, choices are intermediate uveitis, Irwin gas syndrome, gyrate atrophy, niacin toxicity. We know multiple conditions they can cause cystoid macular edema, out of which intermediate uveitis, or rather any type of uveitis, can cause CME. So it is a true choice. Irwin gas syndrome is the cystoid macular edema developing after a complicated cataract surgery. Okay, so this is the true choice. Niacin toxicity, that is a high doses of niacin or nicotinic acid, they can cause the cystoid macular edema. prostaglandins, they can cause cystoid macular edema. Okay, but gyrate atrophy is a degenerative condition of retina. Gyrate atrophy has no correlation with the development of cystoid macular edema. So this is the answer to this question, choice C. Okay. Okay, coming to the last question of the session. Which of the following drug combinations is not used in treatment of glaucoma? Okay, glaucoma drugs, again a very important topic from your exam point of view. So here the question is asking, we know in the treatment of glaucoma, the patient can be on monotherapy, that is a single drug, or sometimes when he or she is not controlled with single drug, you put the patient on drug combination. So which of the drug combination is not used? Okay, the choices given to us are timolol plus latanoprost, timolol plus brimonidine, pilocarpine plus latanoprost, brimonidine plus brinzolamide. Okay, so when we are using the drug combinations for glaucoma, what we are looking for, that both the drugs, they should kind of complement each other. They should enhance each other's efficacy, and their side effect profile should be like that it should not increase the side effects. Okay, so if you see here in the choice A, timolol and latanoprost, they make a good combination. Timolol is aqueous suppressant, latanoprost increases the uveoscleral outflow. So this is a good combination to be used. Then timolol plus brimonidine, again timolol aqueous suppressant, brimonidine has dual mechanism, so increased efficacy. The side effect profile does not increase the side effects in both the combinations. Coming to brimonidine brinzolamide, brinzolamide again topical carbonic anhydrase inhibitor, acts as a aqueous suppressant. Brimonidine has dual mechanism of action, so they also increase the efficacy, right? But if we look here, pilocarpine and latanoprost, okay, pilocarpine increases the inflammation in the eye. Latanoprostin, a prostaglandin analog, also increases inflammation in the eye. So both of these can increase the inflammation. Both of these, they can cause cystoid macular edema. Okay, so their side effect profile is like that individually they produce these problems, and in combination there will be more risk of developing CME or increased inflammation in the eye. So this combination is not preferred. Okay, this combination is the one which is not preferred in the treatment of glaucoma, right? So with this, it brings me to the end of the short revision. The aim of this short revision was to tickle you for regarding the important topics which are there in ophthalmology, and to motivate you to start your preparation with Unacademy. We have many upcoming lessons and courses to provide you with best preparation material. Okay, so you can unlock Unacademy free plan, and you can once again I like to share that you can use a referral code Anuradha I, and so that you the preparatory materials are offered to you. Okay, I'm open to your suggestions, and you can contact me on mail as well as on my Telegram group. Okay, and best of learning, best of luck, and hope to see you soon with another session in ophthalmology.